Hello, everyone, and welcome to our webinar. Today we have a special guest, Michelle Broadhurst, who was kind enough to share a blog post for earlier this week. And as always, we're going to give people a few minutes to join in, settle in, and get ready for an exciting webinar where we talk about myofascial pain and understanding the system within the equine patient. So get ready for an amazing webinar. As always, if you have questions, we have a 15-minute Q&A session that is at the end of every webinar, so feel free to ask. There's no such thing as a stupid question, and we'll try and include as many of your questions as possible. All right, Jochen, I'm going to send it over to you, and we will begin.
Okay, so sometimes it plays right. Here we go. Well, another week passed. It's Friday again, one of my favorite days because I get to speak about my calling. My calling is to protect horse and riders from long-term damage was caused by the saddle. My favorite friend, my best friend who trusted me and carried me over huge fences, came up with the lameness, what we could not detect back then in 1979 to 1981. So being a saddle maker, master saddle maker, and understand for many people who says, you know, I think it's your saddle. I took it very personal because I wanted to investigate that. And I took the advice from my parents and says, you know, surround yourself with smarter people, people who really understand horses. So I made it myself a quest to travel the world and find people from all over the world who study the equine horse. And it's amazing what I have learned and how when experts work together, the real benefit is always the horse. Of course, the owner, because you don't have to go from place to place and say, okay, no, I try this. But I wanted to make sure that nobody loses their best friend like I did from not knowing what I don't know. You know, people care what you do. So for me, it's important to let all of you know, I can make saddles, I can sell saddles, but I can't sell everybody a saddle. So my mission is to surround myself with experts from all over the world, and not just from the bottom of the saddle, also from the top of the saddle. You know, what do gynecologists, what does the medical doctor say? What is important for the rider? You know, so to my astounding as a judge, competitor, trainer, you know, very little did I give empathy to my female students. You know, I never understood why it doesn't work. I had to read it in the book. It does not get taught to you in a saddlery school. I worked in all over Europe as well as in England. And in no saddlery I worked, ever they paid attention to the actual fit to the rider as well. So the anatomy for horse and rider is really lacking, because if I ignore it, the rider will suffer. Down in South America, I met a wonderful veterinarian who brought Saddlefit for Life into the universities, and this is taught there too. And again, Saddlefit for Life, it's a philosophy what is based on science and research. And sometimes we work really, really hard and we look, maybe it is the saddle, maybe it's not the saddle. This veterinarian in New Zealand does autopsy, and she shows how many saddles are really bad designed. And sometimes these saddles are very, very expensive. So we have experts now from all over the world who really open up and says, hey, listen, you can inject your horse, you can treat your horse, but what good is it if I do the treatment to the horse, but the saddle takes away the treatment? A wonderful person I met in South Africa, Dr. Catalina Thiersen, she together with her partner, she has over, her partner is Eileen Davis, and she has dissected over 200 horses, and I call that CSI saddle fitting. So she knows all the horses, how they've been ridden, what tack have they been ridden, and it's astounding what I learned from them. And also, to my great surprise, we have veterinarians who point at the rider, the style of riding. Sometimes you have a good saddle, it fits well, you look after the horse, but the rider itself, sometimes it's not really doing a good job on top of the animal. So here we are, we do everything right, we treat the horses right, and sometimes it's the rider. So who am I as a saddle maker to say, hey, I'm a judge, I'm a coach, and I give my opinion from what I learned. But here we have a veterinarian who says, if you ride like this, your horse will be damaged. And we have many problems when we ride the horse, like you see here, the B horse on the forehand, when they're hollow. And then we have tomography or all kinds of problems when we ride upside down. Another veterinarian from the UK wrote a wonderful paper on the animal expression, what that means when eyes and ears. And I always say the eyes and ears don't lie. Very proud to say this won our educational award. This book I wrote in German as well as in English. And together with Sonia, we decided we got to spread this, what we learned over the last 40 years, all over the world. We have to surround ourselves with experts around the world, share that sometimes you do all the good things treating a horse, but it could be a saddle fitting issue. Sometimes you really look at the saddle, but there is changes, what happens in the last 100 years. The main changes is the breeds. We talked already about the gender of the rider. We have the majority of the riders now females, and we talked about, well, we didn't, but we see horses are not just used for wars anymore or plowing the field or pulling carriages. Some, yes, but the majority are sport horses. And we have a lot of adult amateur riders who finally have the time and the money to ride. So our horsemanship is a different level than before. So it really doesn't matter. Saddle fit for life doesn't matter if you, in the working field, if you look at Western or English or even like bareback, we need to understand, and this lady here from Germany wrote a wonderful book. It's called From Fluchttier zum Dressurpferd, Designerpferd. And that means from the flight animal to the designer horse. Fortunately, it's only in German, but her videos are fabulous, and in English as well as in German. And she pretty much says the main problem we have now is the breeding is going south. We had horses were rectangle and strong in the chest and shorter legs and long backs. Now the horses get bred with very narrow chest, very long legs, very long necks, but very short saddle support area. And our riders get heavier and heavier. So here we are, we're making all kinds of adjustments to fit the saddle, and we're trying to fit the female now in a gender appropriate saddle. Everything is good, but then there may be still some underlying issues. And there might be still some pain the horse experience, and we have to look a little bit deeper. So I'm absolutely delighted that today we have Dr. Michelle Broadhurst with us, and a wonderful person. I have the pleasure yesterday to talk to her, and she is a joy, and I understand she's also at our big webinar on August the 22nd. So I'm delighted to introduce you to Dr. Michelle Broadhurst. Here you see all her contacts, phone numbers, and emails, and we talk today about myofascial pain. Michelle, are you there?
I am indeed.
Thank you.
Hello, everybody.
Thank you so much for coming, and I am going to have my pen and paper ready, and I'm so excited to listen to you. As I could tell yesterday on the phone already, oh my God, this is going to be amazing. So I hand this over to you. The floor is yours. And I'm going to turn my camera off and going to be in the background and can't wait to watch you.
Okay. Can you see me? We good? Jochen, can you just tell me if you can see the screen?
No, not yet.
Oh,
so
okay. Let's try
you hit the share button.
Yep, it's doing its own thing today. Hang on a sec. Oh, goodness me. It worked a second ago. Hang on.
Maybe, Sonia, if you can hear us, you are our technical expert.
Here we go.
All right, there you go.
I think we're good. Yes?
All right.
Cool. Okay. All right. Hello, everybody. Thank you so much for having me. I really appreciate being here and sharing this information with you. So what we're going to talk about today is the importance of manual and myofascial therapy in treating horses. The two go very much hand in hand, and I think it's imperative when we are talking about structural issues or functional issues to remember the structural or the functional, because they really are hand-holding partners, and you very seldom will get as much release for the horse and long-term effects if you're only treating functional or you're only treating structural issues. The two are very much linked. So we're going to talk today about basics. As practitioners, as riders, as saddle fitters, everybody who is involved with your horses, it's very, very important that you know your anatomy and physiology. And one of the best ways to do this is actually just to get your hands on the horse and being able to differentiate normal from abnormal, because so often we get stuck looking at a particular lameness. We think that everything is centered there, but often that is a secondary issue to what's actually happening at a different primary location. And if you are not very aware and very in tune what normal feels like, it's very difficult to feel abnormal and what a normal range of motion, normal tonality, all of those things is very, very important. As much as you can, try to palpate, because your hands are your greatest tools. Diagnostics are wonderful, pharmaceuticals are great, but really the only way to genuinely know what's going on is to feel the differences between the normal and the abnormal. So what we're going to talk a little bit about is there's so many different treatment options with manual therapy. And by manual therapy, that can be soft tissue treatments such as massage, acupressure, soft tissue release, myofascial therapy, myofascial release, using modalities such as laser, extracorporeal shockwave, neuromuscular electrical stim, all those sorts of things, very helpful to change a little bit of a hypermobile area and restricted ranges of motion into a better moving joint, or a more mobile area, if we can say that, because hypermobility doesn't always occur on a joint level. It can actually occur all the way through onto a functional level too. So mobilizations is something that is very big in the physical therapy world. You have 5 different grades of mobilizations. We'll talk a little bit about that today and what they actually strive to achieve. And range of motion is the same. We have 2 different kinds, passive or active. Active is what the patient does themselves. So for example, if you're doing a cookie stretch with a horse, or a carrot stretch with the horse, whatever, depending what country you're in, to get cervical mobilization happening and proper range of motion. That is the horse actively doing it themselves, which has a little bit of a different mechanism to us actually taking the halter, pulling their head around to induce more stretch. So those 2 different movements just on their own have a very different physiological effect on the body, just being an active motion versus a passive. And then chiropractic is a grade 5 mobilization, which is a low amplitude, high velocity thrust. So it means that it's a very specific, very quick thrust in a specific range of motion so that we are getting additional movement in a joint. Okay, so why are we doing all of this? And most of the things that we're looking for is high effectivity, a reduction of pain and inflammation. We want to restore ranges of motion, and we want to restore strength. And that works both on a manual level, so on a structural level, as well as a functional level, because the one works off the other. And we'll get into this a little bit more as we go through the talk. But really, those are your 4 goals: to reduce pain, reduce inflammation, restore normal range of motion, and restore strength to the area. Okay. So where do we want to start? So with anything, we want to use all our senses. We've talked about our hands and touch. Now we're going to use our eyes. And one of the best ways to analyze an animal's movement is by gait analysis. And you always want to have a good handler who's going to be able to get the horse to go in a straight line, up and down, at a walk and a trot, because those are very different movements. They tell us very different things. And dynamically, we will be able to actually see what is going on every limb in every gait. And that's really important to do, because if you have an animal that you are treating or you're looking at in a stall and they are static, their body's ability to function in a static position is very different to what it is in a dynamic one. So you need to take into account that animals are dynamic. They are really only static if they are eating or sleeping. And for the rest of the time, they are moving around. And especially when we're looking at high performance horses, and by that, I mean any horse that is not retired and just sitting in a camp, they are dynamic pretty much all the time. And that is where we start to see the difficulties and the dysfunctions coming through. So once you've done your gait analysis, start to identify the dysfunction in your mind. So have a list of differentials. Okay, he's a little bit short on that off hind leg, he's loading onto that near fore shoulder. He's got a little bit of a functional scoliosis, so he's got a little bit of lag time in his footfall. All of those sorts of things are important. And you should be collecting a bit of knowledge in the back of your brain as to what possibilities those could be. And it could be neurological, it could be structural, could be functional, and then work through your differentials. Once you have a diagnosis, think about the treatment options for the dysfunction, and also the actual horse itself. So I've worked with thousands and thousands of horses. Some do wonderfully with needles, such as acupuncture needles, a myofascial dry needling. Some do much better with a myofascial release type base. Others do phenomenally with chiropractic. You really have to keep in mind the individual themselves, because the way that the brain works is that it changes. The brain's very plastic. So it changes the interpretation of pain depending on the individual. And actually, the pain centers are really in the prefrontal cortex. And what's very interesting about this, and I'm bringing this up a little bit too soon because it is later on in the slides, is the area of the brain that is all about chronic pain and pain perception is the prefrontal cortex, and that is shared with the area that is actually receives information about chronic depression. Fibromyalgia in people is shared in the prefrontal cortex. So it's very, very interesting when you start looking at an animal's disposition and how it has changed. And I have had so many people come to me and say, I don't know what's wrong. He's just not himself. And that's one of the reasons why, is that the brain is plastic. It takes those pain receptors, it takes that perception of pain, it sits in that prefrontal cortex, and the way that it actually discusses with the body how it's going to react to that is through the descending pain pathways. And the imperative thing about that is that the brain can actually change the perception of pain accordingly through serotonin and endorphins, and react in a very different manner. So that is a subject for another day, but it's very interesting when you're watching a dysfunction, how it can be hidden, it can be changed according to various different conditions in the body. So very important, have a treatment plan. And this is where your team comes in. Your myofascial person, your chiropractor, your acupuncturist, your trainer, your saddle fitter, the rider themselves. This is where everybody really needs to sit down and discuss what your short-term and your long-term plans are. My long-term plan is always the highest quality of life that I can possibly give the animal for the longest time possible. But it's important to create short-term goals so that you really know what you're aiming for in a specific time period. Okay, so just quickly, indications for manual therapy. This is really for myofascial too. Is pain on shoulder movement, particularly extension. We see a lot of extension type injuries in the shoulder, and that could be functional or structural. Delayed healing, which is really a neurological effect too. So when there is increased inflammation, it's very, very difficult for the body to actually heal effectively because of the mechanism of inflammation and the biofeedback mechanisms that come with that. Lameness, vocalizational pain, especially on movement, post-surgical pain, holding the tail in an abnormal fashion. Yes, there are certain breeds that this is a standard thing, but if it's outside of the breed standard, then we need to really take hindrance of that. A big one for all of us, especially if we're looking at saddles, is change in posture or having an uneven top line. Because as soon as we start seeing that, we know that something is afoot. Horses work, they try to work as evenly as possible. We don't always allow them to do that, but an uneven top line could be a functional issue, or it could be a training issue. So make sure you look into that. Head tilts, difficulty chewing, and TMJ. I find TMJ is often ignored. And really the TMJ, so the mandible, the maxilla, it all articulates with the C0, C1, which is the atlas, which is one of the primary foundations for the spine. If your atlas and your axis are not in alignment and your pelvis is not in alignment, we're going to see structural abnormalities as well as functional ones, all the way working in a domino effect through the spine. And even muscle development tells us a lot. It could be a disuse atrophy, which means that the animal is not using it correctly, so they're not actually firing up those muscles, or it could be neurological. Changes in gait, shortened stride, bucking, doing abnormal things that they would never normally do, uneven pelvis and hips, same reason as we were talking about the TMJ and the atlas. Tender spots along the back or withers, you guys all know about this, because especially with Saddlefit, when we're looking at, particularly at the trapezius muscle, lat dorsi, places, longissimus muscles, glute medius particularly, those are the ones that get affected predominantly with poor fitting saddles. Back, neck, leg, or tail pain, changes in behavior or attitude like we were discussing before. So again, this comes back to palpate, 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 and this is all about motion palpation. So this is a passive range of motion that we're really doing here, and we're looking for normal physiological movements as well as accessory movements. So the full joint movement and where it's actually being blocked. So end feel is what is felt by the practitioner when they get to the end of a joint, how much spring there is, if it's bony. Most are soft tissue approximation, like if we're looking at the knees or the stifle, it stops because of ligamentous or capsular tension, and that's completely normal. If we're not getting an end feel, that's very dangerous. Please call your vet and have that area x-rayed as soon as possible, because it could indicate a fracture or instability of some sort, and that is not something that we're going to play with, especially in the functional or structural realm. So motion palpating, doing both sides, always start on the good side, move to the bad side after that, so that you've got an indicator of what is normal in that horse, and you'd be able to tell the differences. So we were talking about mobilization. There's 5 grades of mobilization. Chiropractic sits in the grade 5. All the other ones, 1s and 2, really sit within normal range of motion. So it's a very small little movement that we use to just get those joints to move, have better neural output, all of that sort of thing. Grade 3 and 4 is a little bit bigger. This should be done by a professional such as a physical therapist or a qualified body worker who's aware of these grades, because you can do a little bit of damage if you don't know what you're doing. But mobilizations are very helpful to change that pain and biofeedback response so that the muscle actually starts to relax and we get a bit of a sarcomere relaxation in the muscle, which changes the pain and spasm that the horses are feeling. So let's get into the nitty gritty. So myalgia is really what we call muscle pain. It's a very fancy word. We like to use fancy words in veterinary medicine, but really all it is muscle pain. And if we had to describe it, it really is an aching or cramping pain that's sometimes difficult to localize. as it can refer into other tissues. So, for example, very often when you have a poor saddle fit, what is going to happen is especially around the wither area, is that trapezius muscle is going to become impinged, and we're going to get the formation of spasms or myofascial trigger points, which we're going to go into now. And because the trapezius is such an extensive muscle with a cervical and a thoracic component, we start seeing poor head carriage, we see shortening of the shoulder stride, as well as referrals into other muscles, such as antagonists and agonists, which really start to create a whole biomechanical change. And we can't actually identify sometimes even which limb is being affected because of the waxing and the waning of the muscle pain that this animal is experiencing. So myalgia really affects, as we were talking about before, those descending pain pathways. So by activating the muscle nociceptors, which is the pain receptors in the muscle themselves, basically those, as we were saying, the brain changes the response because it goes to that prefrontal cortex and the periaqueductal gray matter, and basically it changes the emotions and how that horse wants to work with you because they're in pain. So if you've ever had a headache and somebody, or a backache, and somebody wants to take you on an adventure and have a great time with you, you're really not a great fun to be around, not because you can't specifically walk or do the action that they're asking, but pain is a great modulator, and it stops the animal from actually wanting to perform at a high level because of this constant pain response that is not only going on in one area, but is actually diffuse and moving to different areas themselves. So never forget that a pain is never just about where the area is. So we're not just looking at a knee that is sore. It is almost like a computer system where it goes into a database and the brain decides how it's going to react to that pain response. So remember that muscle pain can often result because of a joint injury, but it can also result in a joint injury. So what that means is if we have spasm and poor function of a muscle itself, it can actually create a change on a joint level, as opposed to a joint issue creating a muscle issue. So there's this whole chicken and egg situation that is often going on, where we're not always sure which one comes first, because as I was saying earlier, the two happen very concurrently, because the minute there's muscle pain or dysfunction, it causes the joint to articulate in a different manner. And the muscles then change again. And so we have this constant cycle of trauma somewhere, could be joint or muscle. Muscle goes on to try to protect that area from any further damage. So it goes into spasm, it becomes crampy, it changes the way it articulates. The joint then can't work in the manner that it's meant to work. Then we end up with a pain response, which ends up back at trauma, which ends up back at biomechanical dysfunction, which ends up at lameness, and so we go through the cycle. So addressing everything at the same time, whether it's neural based, structural based, functional based, we have to look at this holistically. We need to look at this as a whole and really identify every portion of the dysfunction. So muscle pain can come from pretty much anything: muscle injury, inflammatory myopathies, trauma, endocrine or metabolic dysfunction. There's a bunch. So you pick it, it can happen. So my passion is really myofascial trigger points. We often don't address the fascia. So fascia is this amazing connective tissue net that works like a spider web. It is neurologically very intense. So just if you can imagine a spider web that's floating around, all of a sudden a fly comes and it hits that spider web, it sends little fasciculations all the way through the web to the spider, who now knows it's got a prey stuck in its net. Now the fascia works exactly the same. And if you haven't seen fascia, I think I have a picture for you. No, we don't. Okay. Fascia is that white connective tissue covering on any piece of meat. So if you're looking at a rump roast, you have to kind of, there's this white marbling over that muscle that you have to kind of stab through to put your garlic in when you're going to go and put it in the oven. That is fascia. And we've ignored it in the veterinary world for a very, very long time. It is imperative to actually keeping the structure of the body, and it allows the muscle fiber to slide against the skin and allow for correct movement of the actual muscle muscular system, if we will, against the skin. Now, fascia doesn't only do that. It actually goes around bones. It goes around arteries. It goes around vessels. It is the most fascinating network, and one which I work a lot with because of its integral part in biomechanics. So if you have a fascial adhesion that is not allowing the muscle and the skin to slide effectively, you're getting this. So you're getting friction all the time, which means that there's dysfunction at that area. There's almost like a little speed bump that's happening there. And when that muscle can't articulate and move correctly, we're going to get dysfunction happening all the way through that limb, if it's, let's say, a shoulder or a leg, or through the back itself, through the longissimus, and especially when we're looking at lateral longissimus muscles that go throughout that spinal area. If we're having speed bumps all the way through the fascia, we're going to get a huge amount of dysfunction happening further on down the road because there's only so much compensation that can happen. So I wanted to talk today about myofascial trigger points. When muscle injury occurs, basically there is a change in the calcium ion pumping. So what that means is, I'm going to break it down to be really, really simple. When a muscle is in good condition, basically there is a synapsing between the membranes that allows the muscle to function correctly and allows it to relax and expand and allows it to contract and work efficiently. When we have injury to a muscle fiber, basically the calcium ion channel is broken, which means that we do not now have, we have an over release of a substance called acetylcholine. And this is normally taken away by acetylcholinesterase from these little receptors in the postsynaptic membrane, which allows everything to happen. Now, when we have an injury, this increase in acetylcholine that is not being taken away basically allows for the muscle fiber to be in a constant state of contraction. Okay, when the muscle is constantly contracted, we now no longer have enough blood flow to that area, and we don't have enough ATP, which, if you've heard about ATP, it is actually the thing that allows the muscle to contract, but ironically, it's also the thing that allows the muscle to relax. So when we do not have enough ATP in the muscle, and we have got this constant acetylcholine flood coming in, which is causing the muscle to get shorter and shorter, we don't get that relaxation. So the body creates these little myofascial trigger points, which create taut bands, and basically they become encapsulated and create their own referral pattern to different parts of the muscle and different parts of the body. Now, again, think of it as a little hump in the road, okay? We're not getting a good articulation. If you have an elastic band, you want that elastic band to be functional and strong. If we have a tear in that band and we tie a knot in it, we can still use it, but at some point that weak area is going to snap again. And so we keep on tying a band, tying a knot until we have this tiny little band that doesn't work as well. And that is exactly what happens when we have myofascial trigger points in fascia or in a muscle, is that we lose that proper functionality of that muscle because it can no longer fire and function at the level that it's meant to be doing it. Okay, so when we're looking at older horses, such as osteoarthritic joints, I call this the Cinderella hypothesis. And for those of you who know fairy tales, Cinderella was the one who was doing all the work all the time, and the ugly sisters were sitting around having a beer, not joining in, not giving her any help. So that is exactly what happens in osteoarthritis. Myofascial trigger points will form there because basically there's this constant low-level contracture of muscles, and it's always the same muscles that are working all the time, just like Cinderella, and they become exhausted. So when muscles become exhausted, what happens is they stop functioning, certainly effectively. They try to contain what's going on with them, and to their best of ability, prevent any further damage. And as we know, muscles are designed to be supportive. So when they can't function at that high supportive level, it then goes on to a joint level. And joints are meant to be structural entities, that are allowed to function in a corrective way. When we lose that muscle protectivity, what happens is we start getting a lot more compression of the joints themselves. We get capsular adhesions, we start getting cartilage degeneration, we start seeing changes in the ligaments and in the sinews, because all of a sudden this protective mechanism has been lost, and now everything goes onto a joint level and onto a neurological level, which results in more dysfunction. So a horse with a painful limb that's not fully weight-bearing, very often what you'll see is actually the pain of putting the full weight on the limb itself is less painful than the cramp that is actually being created by the non-weight-bearing leg. So we're getting this constant kind of cramping and exhausting of these muscle fibers all the time, and the horse is always in pain. And this is often why we see a little bit of shifting lameness, is basically the compensations of a painful limb and then going onto the non-painful limb. The non-painful limb ends up being the painful limb because it's taking all the work, just like the Cinderella hypothesis, because of the dysfunction on the limb that's not weight bearing. So really, my reason for telling you all about this is don't ever get stuck on a presumed symptomatic side, because very often the lame leg, yes, there's something going on there that's stopping the horse from weight bearing. It's now holding the leg up. We now have contracture all the way through that limb. And not only do we have it in the area that was initially painful, we now have it in all the associated muscles and the compensations on a joint and a functional level on this lifted limb. But we also have it on the other side, who is now having to do all the work to stabilize, because as we know, stay apparatus in horses, all of that, if we're not looking at the opposite side too, that is taking all this compensation, we're never going to achieve everything, because guaranteed you will always find something in a compensated area that could be as active as the side that is showing the lameness. So please look always on both sides. So for example, if we're looking at the trapezius muscle, I put this one in for you guys because it's so applicable to Saddlefit. Just from doing more than 10,000 horses, this is really where I've come up with these different places for myofascial trigger points. So especially in the trapezius muscle, we do have a lot of trigger points referring to the pole. We have some mid-belly trigger points that refer locally and a little bit cranially. And then specifically around the wither, and I think all of you who are involved in saddle fitting could attest to this. Whenever we have an incorrect saddle fit or we're having pressure around the wither, we will always find these two distinct trigger points that actually don't just refer locally. They go a little bit cranially, as well as slightly ventrally too, so towards the belly. So just never think that just the knot that you're feeling is referring pain to that place. It goes to other places too. So by treating these trigger points, it could be by inserting a needle like here, where we're doing some myofascial trigger point release. We're actually creating a change in the ATP cascade, which allows the reflexive pathway to actually allow the muscle to relax. This can be achieved by various different treatment patterns, acupressure, as we were talking about laser therapy, extracorporeal shockwave, by actually doing dynamic movements such as stretching in certain manners, especially if we're doing PNF and resistance stretching. Some are just quicker than others. I like using a needle just purely because it really allows that relaxation of the sarcomere very, very quickly. It increases mitochondrial production of ATP and increases blood flow to the area. So we want to create little homing beacons when we're looking at treating these different areas, where the body can specifically identify where the dysfunction is by creating a little bit of micro trauma. And people always freak out at that word, but really by using a needle, for example, you can create a twitch response, which basically tells the body exactly where it needs to focus, brings more blood to that area, breaks down that scar tissue production, and then allows that muscle to reproduce normal muscle fibers and get rid of that trigger point. No more speed bumps, the road's been resurfaced, everything's smooth sailing, and all of a sudden that lameness and dysfunction goes away. So I think we're about out of time. I've tried to do this as concise as I can. I'm releasing a book in September, which is a clinician's guide to myofascial pain in the equine patient. It's going to be available on Amazon or off my website, which is www.drmichelleB.com. And this is what it's all about. It incorporates different kinds of disciplines and the things that that we're looking for. There's I think we've got over 30 muscles in the book that we actually go through, from insertion to neurology to how we treat it, where are the trigger points, why are they important. And I would, I hope that it is a helpful tool to all of you. It's been wonderful to write it, and the canine book we've had an amazing result and response from practitioners who have bought that one. So I hope that this is a helpful tool to all of you.
Wow, this was fantastic. So Sonia definitely was right. This is going to be an amazing webinar. Now, unfortunately, it's always so short, and just when you get going, what do you mean you're over? I just got going. And
I only had 30 minutes.
and I'm so happy it's being recorded, because I can't write as fast as you were talking. And I made so many cool notes. And one what really struck to me was one of the first notes when you said, how the brain is plastic, and the prefrontal cortex, and how the horse, and even in human, how we can take it in, and then we say, wait a minute, so you deal with that all of a sudden different with the pain. And the horse, I don't think you said depressed, but it comes, what was the word you used?
Well, it's just a change of personality.
Yes, that's what it is. Yeah, so, it was fabulous. That stuck with me a lot. And what I wanted to, and of course the spider web, that was an amazing story that we all seen. Now, how can that spider feel it?
Yep.
And that myofascial, it really goes everywhere, around bones as well, and muscle and veins.
Actually, there's even something called a double bagging system, where it goes around every organ. It goes around even your arteries and your veins, and even your neural sheaths have a layer of fascia around them. So that's why when we're looking to be really, and I use this word very genuinely, like holistic in our approach, we focusing on one area, like an inflamed stifle. It's never just the stifle. It's never just the back. It's this connectivity, this web of connectivity that we have and that's why I incorporate structural and functional so much. Perfect. Because even blood flow, with having fascial restrictions, it changes the articulation of that blood vessel because of the fascial lining. So all of a sudden we're getting ischemia and we don't know why. And very often it can be something on the other side that is actually causing a restriction. And all of you know this with Saddlefit, is if I have a tight wither, I have dysfunction in the shoulder, I have poor head carriage, I have a poorly engaged pelvis, from 2 or 3 pressure points right up on the wither, bladder 13, all of that, if you're impinging on there, you're changing the entire biomechanic and gait pattern of that horse.
Yes. And what I love about that is exactly what you said. We are saddle fitter. We've seen this all the time. We do our best job, and then the customer tries the best instruction and does everything right, but the horse still performs miserably. Maybe, like you said, the inflammation uses the hog. Everything is looked after the saddle, but maybe the problem comes from somewhere else. And it shows, of course, the second you put the weight on the horse's back, now you implement you increase the pain factor, but the pain might be somewhere else. And I loved how the analogy you gave. And of course, one of my favorite is the Cinderella story. I do have a question, then we got to give it to the audience. Have you ever come across in all your years of treatments where you feel, wow, I did a really good job, and while you pack up your tools and you go in the car and you look in the back of the mirror, you say, oh no, they're putting this bad saddle fit on, and everything you just spent an hour and a half, or God knows how long, it's undone in one ride. And then they come and say, the treatments don't last.
They didn't last, yes.
How do you deal with that in your profession?
I think my biggest aim, honestly, after doing this for almost 2 decades, and I think it's very similar to you, is I really feel that we have to put our egos as practitioners aside and create good tribes. Because if we're all working together for the well-being of the horse, that sort of thing shouldn't be happening. Because if I'm dealing with a veterinarian who has respect for what I do and I have for them, and the saddle fitter, and we all wear a lot of different hats, but I really believe in working to your strength.
Yes.
So, having your team go, don't you dare put that saddle back on, and having the trainer on board and everybody on board so that we can get to that point. I think a lot of it is education.
Yes.
And that is where our biggest downfall is that, and ego, is that people are like, yeah, I don't listen to them. What do they know? The horse looks fine. It's sweating evenly. There's no saddle fit problem.
Yeah, exactly.
And that was the old school thinking. Well, if it's sweating evenly and it's able to ambulate, it must be fine.
Exactly.
I think education is key.
Yeah. And that's why we did Saddlefit for Life, and this is what's all based. Sonia, if you can hear us, do you want to take over and see if there's a question coming in from the audience?
Oh, we definitely have questions. And I have one question for Michelle as well, specifically in regards to horses who have asymmetries, which I'm sure are most of them. But I'll save that for last, and I'll ask the questions from the audience first.
Sure.
So the first one is, how does nerve damage affect muscle? I have seen muscle diminish rapidly in horses with an injury that caused nerve damage.
Yes. So, wow. How long do we have again? Okay. In a nutshell, basically, like I was explaining before. So the nervous system, if I can equate it to a water system, okay? You have the tap where you switch your water on. Now that's your brain, okay? So that's your nervous system. That's your central nervous system. The nerves that come off that go to the spinal cord. They bifurcate and they go to different organs, different limbs, and all those sorts of things. Now the water is flowing, right, from the tap. So the brain and the nervous is working. Now, if you have an injury at a specific area, it's like putting your foot on a hose pipe. All of a sudden, your flowers are dying because the water can't get to where it needs to go. So when there is a neural impingement at any point, basically you get a decrease in neural output. So the actual nerve itself that goes to feed that area is no longer feeding the flowers. So that's why the flowers die. So that's what we call it atrophy, really. So when the muscle cannot be fed correctly by the nerve that goes to feed that area because of an issue either locally or at a different location, and that could be spinal based, or it could be much more specific at a joint or in a muscle itself. When that nerve is no longer articulating, that muscle cannot thrive because it's not getting neural flow, and that muscle atrophies.
Super.
Wonderful. I thought you were going to take at least 15 minutes for that answer.
I'm trying, Sonia. I'm trying to be concise.
All right. Great answer and beautiful analogy. It makes so much sense. And the next question I have is, how do you fix muscle atrophy behind the withers due to an ill-fitting saddle, other than obviously getting a saddle that fits properly? So this might actually be for both of you, but Michelle, I'll let you go ahead with your answer.
Okay, so just behind the saddle, we're either looking predominantly, depending on where you're talking behind the saddle, we're either looking at trap or lat, okay? I think one of the biggest things is actually getting your horse into a correct biomechanical movement. So making sure that they're engaging through the hindquarter and you're getting proper pelvic flexion and extension, because that allows the spine to open up. It also takes away cranial loading, because what we see a lot in horses is that they are taught to be pullers, not pushers, which really just allows, the way I explain this is it's like a guy who always wears baggy shorts, who is in the gym every day, but he never does leg day. He always does shoulders. So he's got this lollipop body, okay? So we're developing certain muscles. So we don't want to have lollipop horses, okay? We want to have beautiful top lines. And that is achieved by actually getting full collection in the hindquarter so that we have correct positioning of the head and full extension through the shoulder. And that is one of my biggest tips, is making sure that you're getting true collection, because once you get true collection, you start getting better articulation through the joints in front, which means that the muscles are activating correctly, and that will build up the trapezius and the lat dorsi.
For me, it starts already with a controversy, because when you ask the saddle fitting school in England, they will tell you, you have to put stuffing in that area, otherwise it hits the withers, and then you have other problem. And then the trainer says, but if you put the stuffing there and you make the tree narrow, how can the muscle ever, if it's properly loaded from behind and the hind leg is carrying more and he is soft in his bit, how can he ever develop the trapezius muscle if the tree is too narrow or the stuffing? The other school teaches a saddle has to fit like a helmet. It's important that the helmet fits from front to back and left to right. A helmet that's too narrow will always slide or gives me a headache. And then the side of the helmet can't just flare out like a sombrero. It needs to fit as well. So if you have a helmet what fits right on the rider, he will not have a super tight chin strap. So if the saddle is properly adjusted, front to end, and then in the width, allow the space for the trapezius muscle to develop, and have the proper shoulder angle through the scapula can rotate through it, and focus on the carrying surface, not on the trapezius. So quite the opposite what the other English or the other saddle fitting schools teaches. So in my profession, I find it a lot, and I don't know if you find it in the veterinarian medicine as well. Sometimes the customer gets completely the opposite advice from the same professional. And I can see how the people out there who listens to us and take webinars and says, okay, so where am I going to go with this now? So my motto is always, if I want that area to come back, well, for goodness sake, do not make it too tight. Let the space be that the horse has a chance to bring his scapular upwards, backwards, and properly move his and use the trapezius muscle, providing, of course, like you said, Michelle, the horse is loaded properly from behind. Mm-hmm. So is that the same in your trade, that you find sometimes customer get conflicted information from the same professionals?
All the time.
All the time. I think also sometimes it's they misunderstand, and that's why I like to use pictures. Pictures say more than 1,000 words, but that's, I think, a big problem. Mm-hmm. Sonia, any other questions?
Yes, and a wonderful explanation for that from both of you. So thank you. And the next one is how to fix an overdeveloped muscle at the pole between C1 and C2 when the rest of the neck is underdeveloped. And I'm going to go out on a limb here and say that the overdevelopment between C1 and C2 might actually be swelling. So Michelle, I'll let you take that over.
So again, it's one of those things where palpation really comes into play, as well as gait analysis. So very often what I find at C0, C1, when we're having issues up there, is it could be a multifactorial thing. So I'm going to give you a couple of differentials that you can take away with and go and look at. Is one, bit choice. How is the bit articulating as far as the TMJ articulation with C0, C1? Are they over, where is their head carriage? Is it in the correct line? Are we where on the vertical are we? Because that makes a big difference too. Because if I'm going to sit like this all the time, I'm going to have huge amounts of pain in my posterior occipitals. I'm going to have issues in my trapezius because I'm overloading through my extensors. So it really comes down to those things, making sure, one, the pole is intimately related to the pelvis and the sacrum. So if we are not getting correct movement and we're not engaging through the hindquarter, we're always going to have poor head carriage. And people, for some reason, believe that they can control a 600-kilogram animal using their hands. Okay, that's not how riding works. Everything has to come from the power from behind. If we are using power from behind, the horse does not have to strain cranially, which is often what happens. If I'm in this position, I'm not going to build these muscles ever. So if my head positioning is incorrect and I'm underdeveloped through my my scalenes and my SCMs, it's because my extensors are so tight. So the nuchal ligament is being stressed from the pole all the way down to the sacrum. If we're not getting the correct relaxation of that nuchal ligament, we're going to have poor head carriage. So my advice would be, one, look at your bit, look at your positioning of your head carriage, look to see if you're cranially loading. Are you getting correct collection and engagement through the hindquarter? Do you have the Beyonce butt that we are looking for? Okay, that beautiful glute medius muscle, those beautiful quads that are creating that hindquarter. I so often see these skinny little butts on horses and these completely overdeveloped shoulders. And my clients will go, "Don't you think they're in great condition?" And then I tell them some things.
You tell them the gym story with the baggy pants, right?
Kind of. We have a little bit of a come to Jesus, because these muscles are not developed. They are not designed to be the pulling structures that we want them to be. The hindquarter is where the power is. So if you concentrate on riding correctly, getting the pelvic engagement and that hindquarter engagement, really the reins are just something to guide the horse in the direction that you want them to go. There shouldn't be any pulling. There shouldn't be any kind of seriously heavy bit in their mouth, because they're already in the correct position to actually have the right head carriage and not be over on the vertical.
Wow. Wonderful. Thank you so much. And that actually concludes this webinar. I'd like to thank everyone for joining us, submitting your questions. And Michelle, thank you so much for joining us and sharing your knowledge, which was absolutely amazing.
You're
so
welcome.
Many people. And I am so excited that you'll be joining us for our web conference. So before everyone logs out, I just want to mention that we have a huge web conference coming up on August 22nd. And right now we have member pricing available to everyone. So you don't actually have to be a member to the Academy, but you can still get the member pricing. And it features several guest speakers, including Jochen, including Michelle, and it is going to be something that every single horse person should attend. So I will put the link down in the comments. And once again, thank you all and have a wonderful weekend.
Thank you. Talk soon, Michelle. Bye-bye.
Take care.